Good morning, everyone. Welcome to day 3 for 7th annual Advances in Congenital Heart Disease Summit, Transfers of Great Arteries, the master class. Everyone enjoyed the gala dinner last night. It was so great seeing everyone. We have a really fun morning today. Today we'll be talking about information management and data science in medicine. We truly have some of the national leaders in this area talking this morning. Very excited for the session. So my co-moderators are Dean Colleen Cook and Jeff Jacobs and Ashu Tandon. Ashu is one of our senior faculty at Cleveland Clinic. He's the director of cardiovascular innovation in the Children's Hospital, as well as leading cardiovascular, the head of innovation for the Children's Hospital, director of cardiovascular innovation in our heart center. So our first speaker today is my colleague, Dr. Tara Karamlu, who is talking to us today about lessons learned from the CHSS database. Tara, thank you so much for joining us this morning from warm Cleveland. Oh, you're in Denver now?
Thank you, Brett. Actually, I'm in Denver. You can see my lovely hotel room behind me. Chairing a program committee. So sorry I can't be with all of you, but I'm looking forward to a robust session and discussion. So I'll be speaking today on lessons learned from the CHSS on managing complex congenital heart disease. So, as usual, before doing my talks, I turn to the dictionary to really understand what some of the words we take for granted really mean. And a lesson actually is defined in many ways, but the first definition is a passage from a sacred writing read in service of worship. It's also defined as a piece of instruction, a reading or exercise to be studied by a pupil, a division of a course or instruction, something learned by study or experience, and a reprimand. Having a little bit of trouble advancing these slides. There we go. So with that definition, I elected to modify the topic of my talk to knowledge from the CHSS on managing patients with complex congenital heart disease. I am a consultant for Edwards Life Sciences, but nothing, no disclosures that would affect the content or bias this talk in any way. So courtesy of Jeff, who just submitted this for publication, the academic impact of the CHSS as a society is quite impressive. Of 12 prospective multi-institutional cohorts that are shown on this slide, and the ones highlighted in yellow are those actively enrolling patients, there has been over 59 peer-reviewed publications since the inception of the data center. This slide demonstrates publications per year from 1987, which was the beginning of the data center, by Dr. Kirkland and Dr. Blackstone over time through the present day. This arrow marks the start of the first CHSS fellow, as it was named at that time, Dr. David Ashburn. Dr. David Ashburn was a good friend of mine who I first met in 2003 when I attended a work weekend at the CHSS in the fall of that same year. David, true to his form, was wearing cowboy boots, jeans, and his Bible tucked in his back pocket, which was very common attire for David. He really was a larger-than-life character and was one of the inspirations for me to apply for the CHSS fellowship that next year as a general surgery resident. David and I remained close friends, and when I went back to general surgery residency, David encouraged me to apply to the University of Michigan for cardiothoracic surgery. After visiting David and Candace and their family that next year, I was sold. And on match day, David called me and said, "You're following me again, Karen Lou. Welcome to the big house." And I replied, "Game on, David," excited for what the future held. Sadly, however, 2 months after that day, I received a call from Dr. Beauvais on June 5th of 2007, informing me that David, along with 5 other colleagues from the University of Michigan, had died in a plane crash. That was a very tragic day. David, true to his selfless form, actually had volunteered to take call that night for one of his co-residents who was scheduled for lung procurement but was ill. David died on the eve before the start of his congenital cardiac surgery fellowship, the beginning of his dream to become a congenital heart surgeon. He will be very missed. Today, the agenda that I'll cover starts with the scope of the problem for single ventricle management. And we'll talk about the evolution of care for complex congenital heart disease and using data to solve complex problems. We're going to talk about case mix and interactions and pulmonary atresia intact septum. The scope of the problem in terms of single ventricle management is a large one, as articulated by Danford and his colleagues in this 2015 article, in which they chronicled over 43 hospitals participating in the FIS dataset, in which there were 11,122 babies with hypoplastic left heart syndrome admitted over 9 years. The total length of stay was 277,000 inpatient days, and total billed charges for this patient cohort was nearly $4 billion, the bulk of which occurred during the interstage period following stage 1. So with this, when I was the Kirkland Ashburn Fellow, as it was renamed for Dr. Kirkland and the late Dr. Ashburn, following his death in 2007, I decided to study center and surgeon factors as they related to the management of complex congenital heart disease and the outcomes of those patients. Interactions and neutralization of risk factors has always been a major interest of mine, as is population health. I wondered how we could utilize the academic data sets of the CHSS to overcome these problems and generate new knowledge. Inherent of this was the concept that Dr. Williams often spoke about, and that is leveling the playing field and adjusting for case mix, such that institutions and surgeons could be fairly compared and their outcomes benchmarked. I used a composite of prospective enrolled cohorts that included transposition, which we've heard about already, the Norwood, interrupted aortic arch, and pulmonary atresia, intact ventricular septum. We constructed parametric models for time-related mortality based on the total aggregate experience of institutions, accounting for all the factors that might be at play in terms of the outcome. The impact of each institution was evaluated separately, and then we looked at the concept of neutralization with interaction terms for each institution and surgeons. Institutional experience was considered within the models, and individual performance at institution was indicated by something we're very familiar with, thank you to the STS and Dr. Jacobs, who will talk next, using the concept of actual survival minus predicted survival, or that survival that is expected after risk adjustment. Experience, which is a very challenging concept, was a multi-domain concept in this study that looked at several domains, including cases per year, case velocity, the rank order of cases, and the total institution and surgeon volume. This slide demonstrates the 1-year mortality risk amongst 3 of those domains: the total cases per year or annual case volume, the rank order of cases, whether it was your first case or your 200th case, and the total case volume of that institution over the study cohort period. And notice that institutional factors were really only operational, or experience factors rather, in transposition, which we heard about in my first talk, and was unimportant relatively in all of the other cohorts. This nomogram, which shows the mortality risk as a function of increasing cases per year, shows the same thing graphically. The line is flat, indicating that annual cases per year did not improve survival. This also shows this, corroborating it by segregation over the highest volume institution compared to all others. Note the overlapping confidence intervals, again indicating no volume outcomes relationship for the Norwood operation. Same thing was seen looking at individual surgeon volume within the Norwood operation. These histograms now show the 5-year mortality in the Norwood operation. The slide is a bit complicated, but it's worth taking you through it, so bear with me for a moment. Shown on the vertical axis is the difference between actual and predicted survival. Therefore, if you are at the 0 line, you're performing as would be expected after risk adjustment. If you're above the line, you're performing better than expected. Those institutions below the horizontal are doing worse than expected. The codes of the different institutions are shown on the horizontal, and the number of patients within each institution is shown in this inset. Institution 18, shown in red, which took care of 43 patients having the Norwood operation in this particular study, is performing the best in the Norwood institution comparatively. The institution with the highest number of patients enrolled, institution 30, which had 155 patients, is doing about as well as expected. And institution 43, which is doing the worst, took care of 19 patients. So the take-home message here is, why is institution 18 doing so well in managing babies after the Norwood operation when they're not by far the highest volume institution? This graph demonstrates one reason why that might be the case. This is a risk-adjusted nomogram for mortality in the Norwood operation, now as a function of increasing birth weight. Institution 18 is compared to all other institutions, and note that the confidence intervals do not overlap here. What this graph shows is that institution 18, in managing low birth weight neonates, 2.5 kilo neonates, do better at institution 18, a very high risk population with large event number. Therefore, institution 18 has learned something about the management of low birth weight newborns that other institutions don't know. And that is one of the reasons for the better outcomes in institution 18. Looking at pulmonary atresia intact septum in the same way, the same graph is shown as we've taken you through before, but note the difference now. The best institution in managing patients with pulmonary atresia intact septum out to 10 years is this institution, institution 14, which took care of 20 patients. Let's find institution 18, which is here, which did so well in the Norwood operation, but they're not doing so well in managing patients with pulmonary atresia intact septum. So we wondered why this was the case. These graphs that were part of Dr. Ashburn's initial paper, which was published in 2004, show potentially the reasons for the good performance in institution 14. This is a competing risks nomogram that demonstrates the 5-year prevalence of end states as a function of the tricuspid valve Z-score. This shows that a balanced institution does the single ventricle approach, the Fontan, in babies appropriately with low tricuspid valve Z-scores and hypoplastic right hearts, which cannot be recruited into the two ventricle circulation, whereas they leverage the biventricular approach in babies with more normal tricuspid valve Z-scores. Death is relatively low across the spectrum. Contrast this to an unbalanced institution, which overutilizes the two ventricle approach, even at very low tricuspid valve Z-scores, and underutilizes the Fontan. Death is almost twice that in institution 14, which follows a morphologically driven approach to the management of babies with pulmonary atresia intact septum. This graph now shows another take-home message from the CHSS. In this graph, the institutions that contributed to all 4 cohorts that we just talked about are shown here. The rank order of the institutions now is shown in these dot plots, and the geographic icons here demonstrate which cohort we're talking about. Note that no institution is ranked 1 in the management of all 4 cohorts. Institution 18 did very well in the Norwood operation, but not so good in pulmonary atresia. Different institutions are better at managing different lesions. This is not unfamiliar. Just because you play the violin well does not mean you'll play the piano equally well. 4 on the floor. That's what we called coronary artery bypass graphs that had 4 graphs at the University of Michigan. And these are 4 CHSS Kirkland Ashburn Fellows at the Toronto AATS. Dr. James Meza, Dr. Anusha Jaga, Dr. Paul Devlin, and myself. A happy group. I want to skip through this a little bit because I know we're running short of time, but I wanted to get to these 2 slides. Pulmonary atresia intact septum, we've seen that the tricuspid valve Z-score is operationally important in informing early survival and the achievement of a definitive end state. But is it informative in late outcomes, exercise capacity, and health-related quality of life? To answer this question, we exercised and surveyed the survivors of the original PAIVS cohort about 15 years later. And what this shows is the results of the health-related quality of life instrument. This is physical functioning scores in normals, shown in yellow, and patients with pulmonary atresia as survivors some 15 to 20 years after their initial operations. Note that the pulmonary atresia intact septum patients did not do as well as norms in terms of physical functioning. However, psychosocial and emotional domains tell a different story. In many of these, the patients with pulmonary atresia intact septum outperformed age and gender matched norms. In other words, patients with pulmonary atresia feel as if they are doing well despite important physical limitations. We've seen this in many patients with chronic conditions, and it's an important lesson that patients don't limit themselves from certain domains. Exercise capacity was another very important aspect of this study. The peak VO2 is also informed by the tricuspid valve Z-score as a newborn. Shown here is the increasing peak VO2, again late, as a function of the initial tricuspid valve Z-score. And note here the different slope of the biventricular line such that patients in whom their ventricles can be recruited into the systemic and pulmonary circulation as a two-ventricle heart exercise better than patients with a 1.5 or single ventricle circulation. So the lessons from the CHSS, or rather, best put, the knowledge gained from the CHSS owes a lot to the CHSS Kirkland Ashburn Fellowship and the inaugural fellow, Dr. David Ashburn. And Lewis Carroll said it really well. I'll believe in you if you believe in me. Is that a bargain? Why, sometimes I believed as many as 6 impossible things before breakfast. And I've changed this somewhat to what's titled on the slide, Belief in Teams Achieves the Impossible. Thank you.
Thank you, Tara. Great talk. We're next going to move on to Dr. Jeffrey Jacobs, who will be talking to us about lessons learned from the STS database.
Well, good morning, everybody. First, I'd like to congratulate Tara on a great talk. It's a fact that one of the highlights of my career has been my collaboration with Tara. She's brilliant, and we've done some great work together, and that was just another excellent presentation. My task today is to summarize the STS congenital heart surgery database in a session that's focusing on information management and data science. So what this talk really focuses on is utilizing data in pediatric and congenital cardiac care to improve in the intersecting domains of outcomes analysis, quality improvement, and patient safety. And over the last 20 years, the STS congenital heart surgery database has advanced the science of outcomes analysis in all 8 of these domains. And sitting in my laptop computer is hour-long talks on each of these topics. So what I'm going to try to do in the 15 minutes allotted here, or maybe even closer to 10, is to spend 1 or 2 minutes on each of the first 4 of these topics. All of the information that I'm presenting today has been published in the Annals of Thoracic Surgery in a series of articles about outcomes analysis, quality improvement, and patient safety. And these articles have been updated year after year, so anything I talk about today can be found in these manuscripts. So let's start a little bit with nomenclature, because to have a database, the first thing we have to be able to do is talk the same language. Back in 1936, Maud Abbott, this was one of Hani Najm's Jeopardy questions. Hani Najm had a Jeopardy question about who published the first Atlas of Congenital Heart Disease, and this was done by Maud Abbott in 1936 at McGill University. But this clearly did not solve the problem of the nomenclature of pediatric and congenital cardiac care. It started the discussion. And here's some examples of the challenges. This is pictures taken from Gus Mavroudis' textbook at Children's Memorial Hospital in Chicago, describing 4 types of ventricular septal defects. VSDs are the most common lesion that congenital cardiac surgeons fix. This is 4 types from the Chicago textbook. This is the textbook where I trained at Great Ormond Street Hospital in London with Bob Anderson, Diane Spicer, a totally different set of terms to describe VSDs. And then this is from the textbook from Harvard with Aldo Castaneda and Richard Van Praagh, another set of nomenclature for VSDs. So back in 1998, we made a computer-generated map of the ventricular septum. Onto that map, we deposited the Chicago nomenclature, the London nomenclature, the Boston nomenclature, and we created a unified VSD nomenclature. We then did that for every lesion of pediatric and congenital cardiac care. We published that in the April 2000 Annals of Thoracic Surgery in a 300-page freestanding supplement titled the International Congenital Heart Surgery Nomenclature and Database Project. Simultaneously in Europe, in cardiology in the young, the Association of European Pediatric Cardiology published another nomenclature for pediatric and congenital heart disease, which wasn't quite the same, and they were published within a month of each other. So then that led to this formation of the leaders of each of these 2 groups to make the International Society of Nomenclature for Pediatric and Congenital Heart Disease. This group then spent a decade creating the International Pediatric and Congenital Cardiac Code, which is available at ipccc.net. We were then collaborating with the World Health Organization, and the nomenclature of the IPCCC has now been adopted by the World Health Organization and is the official nomenclature of ICD-11, which has not yet been adopted, but will be adopted sometime in Europe in the next few years and probably about 20 years in the United States. But the nomenclature for ICD-11 is now the IPCCC. It's the first time that clinical and administrative nomenclature for pediatric heart and congenital cardiac care has been unified. And this ICD-11 now has 318 terms for pediatric and congenital cardiac care, and this nomenclature is used in essentially all databases that track outcomes on a national and international level for pediatric and congenital cardiac care. So once one has a nomenclature, agreed upon terms, which we have better now than ever, the next step is the creation of a database to capture data. We know that in the United States, there's approximately 125 hospitals that perform pediatric and congenital heart surgery. We also know that in Canada, 8 centers perform pediatric and congenital heart surgery. This is a slide showing the growth of the STS congenital heart surgery database year after year after year after year, from the time the database first started collecting data in 2002 up until the beginning of the COVID pandemic. And we can see that the overwhelming majority of hospitals in the United States now submit data to the STS congenital heart surgery database. This allows us to analyze in a 4-year analytic window over 150,000 pediatric and congenital cardiac operations. And the overall database now has actually over 500,000 operations. What this means is that the overwhelming majority of hospitals in the United States that practice pediatric and congenital heart surgery submit data to the STS database, and therefore the data in the STS database is representative of the state of the art of pediatric and congenital cardiac surgery in the United States. The next step, when you have terminology and you have a database, is to find a way to adjust for the complexity of the patients who receive care. And we use 2 tools, risk stratification and risk modeling. I'd like to spend about 60 seconds on each of these 2 tools. The reason we use risk stratification is based on some simple facts. When the STS adult cardiac surgical risk models were developed for coronary artery bypass grafting, they were developed based on about 50,000 coronary bypass operations performed per year. And 80% of the adult cardiac surgery operations in the United States are CABG, AVR, MVR, or combinations of these operations. Meanwhile, when we tried to make risk models for pediatric heart surgery, we had about 1,600 VSDs, 400 switches, and 700 Norwoods per year performed in the United States. And to get to that 80% threshold, we had to use more than 150 operations instead of variations on 3. So risk modeling was a little bit challenging. We used risk stratification, where we divided data into relatively homogeneous groups called strata. 3 tools have been used to stratify patients in the STS database. We started with the Aristotle score and the RACS score, which were based on expert opinion, and then eventually we developed the STAT categories based on actual objective data. So, as I said, RACS and Aristotle were developed by a group of people sitting in a room, experts, saying this is a low-risk operation, a medium-risk operation, or a high-risk operation. And the tools work pretty good. So this is the 6 categories of the RACS tool, 45,000 operations, and we can see how discharge mortality increased from Category 1 up through Category 6. Category 1's an ASD, Category 6's are the Norwood operations. Similarly, this worked pretty well with the 4 levels of the Aristotle tool. But then we said, let's use actual objective data instead of expert opinion. We developed the STAT mortality score and categories. This was done through a collaboration of European and North American centers. 77,000 operations were utilized, 33,000 from Europe, 43,000 from the United States and Canada. This is how it works. Procedure-specific mortality rate estimates were calculated using a Bayesian model that adjusts for small denominators. That's obviously a sentence written by a statistician, not a surgeon. But what that really means is that the operations are sorted by increasing risk and grouped into 5 categories that were designed to minimize within category variation and maximize between category variation. So we had these 5 categories. And then we looked at this with European and North American data, and we were able to generate this graph showing as one progressed from Category 1 ASD, Category 2 VSD, Category 3 tetralogy, Category 4 switch, Category 5 Norwood, discharge mortality increased. And this was a tool to stratify the risk of patients. Then we said, let's try to develop some risk models that adjust for more than just what operation was performed. And in 2014, we published the first STS congenital heart surgery database mortality risk model. This was a model that adjusted for all of the variables on this slide: the age of the patient, the primary procedure, weight, preoperative risk factors, including was the patient on the ventilator, was the patient on ECMO, did the patient have renal failure going into surgery, a preoperative stroke, chromosomal abnormalities, and syndromes. We looked at 52,000 operations, 86 centers. We learned that if we used the stat categories alone, we had a pretty good C statistic. So the performance of the model was pretty good. If we added in age and weight, it got better. If we added in the specific patient factors, we even got better. If we replaced stat categories with a variable for the primary procedure, age and weight of the patient, we got better. And the best model of all, which was the best model to date for pediatric and congenital heart surgery, was the risk model that used all of the variables shown on the previous slide. And that was the final model published in 2014 and utilized for STS outcomes analysis from 2014 till about 2018. Then in 2018 and 19, we enhanced that model by providing enhanced adjustment for chromosomal abnormalities, syndromes, and non-cardiac congenital anatomic abnormalities. And this information was published in 2018 and 19, and consequently is now the model that we use for risk adjustment in the database. It uses all of these variables, but there's now specific adjustment for what type of chromosomal abnormality, syndrome, or non-cardiac congenital anatomic or abnormality is present in the patient. I have just a few slides to show about verifying data, because if you have the language, you get it into a database and you adjust for complexity, it doesn't mean anything if you don't know that the data is complete and accurate. So STS has a very vigorous program where we audit the data of the programs participating with site visits both virtually and remotely. And we published the outcomes of 10 years of data verification in the World Journal for Pediatric Congenital Heart Surgery. This study was led by David Overman, who's the president of the Congenital Heart Surgeon Society today. And in this audit study, we found that by auditing 10% of the sites every year, the completeness and accuracy of the data in the database was quite good, as shown by the numbers on these slides, especially the mortality, which was really good. The mortality data was extremely complete and extremely accurate. The only mortalities missed are patients who had PDA ligations and then went back to the referring hospital and died remotely in the NICUs at the referring hospital. And again, here's the mortality status from the most recent audit that was published by Dr. Overman. So I've gone quickly through each of these points. There's a lot more details for each of them. I'd like to spend one more slide to talk about a recent publication that exemplifies the last set of points about linking databases, longitudinal follow-up, and quality improvement. We recently published this paper in the New England Journal. I had the honor of being the PI on a NIH-funded U01 grant where we randomized 1,200 neonates and infants at 54 centers to receiving steroids versus no steroids prior to cardiopulmonary bypass. And the research question was important, but what was more important was the ability to structure a randomized trial within a registry. And that's actually why the NIH funded this study, not just because of the research question, but also to demonstrate the fact that one can answer research questions using a registry like the STS database as a platform to conduct a randomized trial. And that, I think, is an example of where we're going with database research in the future, to answer questions like this question, utilizing the power of the database that we've built. Science tells us what we can do, guidelines tell us what we should do, but registries like the STS database tell us what we're actually doing, and using the power of that information can teach us how to do it better. Or, as said by Deming here, without data, it's just an opinion. Thanks.
Good morning. I will be talking to you this morning about lessons learned from the Cardiac Neurodevelopmental Outcome Collaborative Database. Talking about the CNOC history briefly, current member institutions, the CNOC vision and mission, which is critical to understanding why we built, what we built, and how we built it. Evaluation protocols that impacted our database creation. Specific infrastructure, goals of the registry database key components and the tabs, data entry, processing, monitoring, and utilization flow map, and then how we're now working with a group called Cardiac Networks United, which is a network of networks, which we'll talk about. And I'll spend a few minutes on the lessons learned. So we talked about this a little bit yesterday, how Jay Newberger back in 2011 brought about a dozen of us to Boston to start these discussions. CNOC came out of those discussions. Within a year, we started having a national meeting for CNOC. By 2015, we were incorporated as a 501c3. And it was really out of those first discussions about 11 years ago now that CNOC was born. So relative to when you look at the STS, you look at the CHSS, this is a much, much, much younger database and really has only been collecting data for a couple of years. So we talked before about this coming together of Jane's meeting in Boston and then our putting together the first neurodevelopmental guidelines in 2012 that got published by the AHA and the American Academy of Pediatrics. We had the first symposium, we said 2012, CNOC Incorporated 2015, 501c3 2016, and unlike the federal government, we've had 3 transfers of power peacefully in CNOC. From 2016, when myself and Jackie Sands were the inaugural chairs of CNOC, to Drs. Goldberg, Sood, Miller, Cassidy, Pavandi, and Wolf. And I want to point out these leaders because when you start a new organization and you start building a new database, it is very, very labor intensive. And I think these other 7 individuals deserve a huge amount of credit. So as we said, established 2015, I mentioned this yesterday, our journal is Cardiology in the Young, and I want to thank Jeff and the other editors of Cardiology in the Young. Without specifically having our own journal and having the ability to put our papers and our guidelines in a place that people go look for them, we would not have gotten people to buy into CNOC and would not have gotten them to join CNOC and pay the $7,500 a year to participate in the registry. And we'll talk about the finances in a few minutes. There are currently 45 participating institutions, more than 1,000 members across 3 countries. We're now expanding into Europe aggressively. We expect they'll have more than 70 sites soon. And Jeff talked a few minutes ago about penetrance. And I think it's really, really important that we got appropriate penetrance in the US and Canada first, and now we're moving into Europe. So the vision of CNOC, it's a multi-center, multinational, multidisciplinary group of healthcare professionals committed to working together and partnering with families to optimize neurodevelopmental outcomes for individuals with pediatric congenital heart disease through clinical, quality, and research initiatives intending to maximize quality of life across the lifespan. These are not just words. These specific items in this vision statement went into what we created in our database. The mission was to determine and implement best practices of neurodevelopmental and psychosocial services for individuals and their families with pediatric and congenital heart disease through clinical, quality improvement, and research initiatives. So how do you create a database that can achieve that vision and that mission? One of the first things we did when we were forming back in the 2011 to 2015 period was create 2 subcommittees. One was looking at the birth to 5 recommendations to add to the AHA-AAP recommendations, and then a school age group from age 6 through graduation from high school, with the idea that what was put together by these, and these are international groups of individuals who are experts in these specific areas, these would be the beginning of our data dictionary. And your data dictionary, when it comes to a database, is everything. Jeff talked about nomenclature. Jeff talked about how you pull that data. The data cannot be gray. It cannot be, we're not sure. That's the only way that you can get appropriate data in. Infrastructure is everything. And, you know, both Tara and Jeff did not talk about infrastructure. The CHSS infrastructure is exquisite. The STS infrastructure is very, very significant. There are literally, you know, dozens and dozens of people that work just on those databases annually. With CNOC, we had to start from scratch. We literally had nothing. We had no one. We had a group of centers that wanted to work together. How are we going to do that? So the first thing we had to do was create a neurodevelopmental core, which is at Children's National Hospital, a data coordinating center, which is at University of Michigan, a data analytic core, which is at Boston Children's Hospital, and then we had to find an IT partner to create our platform. It's a really, really important lesson learned. If you don't have to repeat collecting data that's already being collected, don't collect it. So given that PC4 and PAC3 were already working through Arbormetrics, we chose Arbormetrics because we didn't have to collect any specific clinical data on these patients about their diagnoses, their perioperative course. We had all that data. What we didn't have was the neurodevelopmental data. So that's what went with Arbormetrics, and literally CNOC is a submodule within PC4, so that this way we can literally link that data seamlessly without any DUA problems or data linkage problems. So the goals of the registry, and I'm going to choose the words registry carefully here, because obviously it's a research database as well, and I'll talk about that in lessons learned, was obviously to create research findings that can impact clinical care. And then we wanted clinical care to feed into the database so we could answer the research questions. And obviously we wanted the clinical care, what we learned, to then feed into improvement opportunities. And ultimately we wanted to perform large multi-center clinical research and QI projects. So the details on the next few slides really don't matter to this discussion, but I want to show you them briefly. So remember, incorporated in 2016 officially as a 501c3, because then we could collect money. We had to collect money for 2 to 3 years to get a bolus of dollars that we could pay our infrastructure. Once we paid our infrastructure, now we could actually start creating the actual database itself. So first, data dictionary, it's everything, and it has to be exquisite. We spent literally 3 years working just on the data dictionary. Then we launched first the 0 to 5 year infant child part of our database. Most of the centers in CNOC were collecting that data already. Not as many were collecting the school age data. So we went with who is our community, what are they doing, what are they collecting? Then we launched the school age database. We created a very specific medical history form that was additive to the PC4 data form. And then in 2021, after 2 years of entering data, we locked the database, we reevaluated the database, we modified the database, and now we're on version 2 in 2022. And that evolution of your database is really important. You can't think of a database as ever being done. The foundational pieces of your nomenclature, that should not change unless science dictates that you change it. But what you may include as science expands, as clinical opportunities expand in terms of QI projects, that may modify what you include and that may expand your data dictionary. So developing the 0 to 5 module, we did incorporate social determinants of health at that time, and I want to emphasize this. When you're talking about outcomes in children and adults, but specifically in children, where they come from, what their zip code is everything. And measuring social determinants of health is not just measuring someone's race, someone's ethnicity. It's much more than that. And while we initially, when we built this 4 years ago, started with your zip code, your race, or ethnicity, we've now in the last year in version 2 expanded that dramatically to look into, do you live in a food desert? Right? What access to medical care do you have? In your zip code, what kind of transportation do you have? These are very, very important pieces that impact outcomes. And then we obviously had to come up with not just the neurodevelopmental pieces, but also the psychological and emotional diagnoses, and then the therapeutic services that these patients receive, because these babies, our cardiac babies, receive significant habilitative services, and this did not exist in any database that we were aware of, in any of the surgical databases or PC4, and it's critical to us basically looking for confounders that would modify our data. School age module. Obviously, COVID-19 blew up all of our opportunities. Remember, we opened in 2016, and literally 3 years later, on this steep rise, COVID hit. Well, that's a problem, because now no patients are coming to a hospital for 2 years, especially for neurodevelopmental follow-up. So CNOC built a very robust telehealth platform, and we were still entering data, but now through a telehealth opportunity. When it came to the medical history form, we knew that there were a group of centers. Remember, we're 45 centers. PC4 is 80 now, and there will be centers that were not part of PC4 that were part of CNOC. Well, we still had to get that medical data, so we had to come up with an alternative strategy, a second stream of data entry to get those patients in that were not part of PC4. I told you how we locked the data and we transitioned to version 2, and then one of the SIGs, the groups that got developed within CNOC, was basically a functional oral intake group, and they created a scale that we then added into the database. Again, we expanded the data dictionary, and then we also expanded our schooling options relative to the data dictionary. Here are the data tabs. Again, the details don't matter, but we have history, we have our assessments I told you about, 0 to 5, and then the school age, the medical history form. Remember, in the mission statement, we said quality of life. You have to have quality of life data in there, and that was very important to us. And obviously, you can't do a neurodevelopmental database and not have imaging data. So to date, we've enrolled more than 6,700 patients. Now I want to do a little level setting here. The Boston Circulatory Arrest trial was 435 patients. The SVR trial was 460 patients approximately. Those are the biggest cohorts we have, inception cohorts, that we can get neurodevelopmental follow-up on now. And as we said, Boston Circulatory Arrest is now almost 25 years in terms of getting follow-up, 35 years in existence. Right now, CNOC is gathering 260 assessments per month. So in a year, we're going to have almost 3,000 patients a year at 45 centers. Well, right now it's 33, but soon we'll be up to 45 centers collecting data. So we will be able to put together data sets that no one's ever put together before, multi-center data, and this goes to some of the comments we talked about yesterday with Dr. Frazier. Single center data doesn't help you. Single centers do things very differently. Having multi-center data that you can control for is very, very helpful in terms of identifying what the issues are and aren't. You have to have a very rigorous data entry, processing, monitoring, and utilization flow map. This is our flow map. You'll notice if you look here in the bottom left corner, member institutions put data into the registry that then goes to the data coordinating center. Error reports are generated back to the member institutions and the data is corrected. Data coordinating center does data monitoring. It sends data to neurodevelopmental core. There's again de-identified error reports, and then the database implementation committee basically fixes, corrects, and re-educates as needed. And then we pull clean data sets out for our DAC to then do appropriate research in the quality improvement and clinical research area. You have to be this specific about what you do and how you do to have good data to analyze. We talked about CNU before, Cardiac Networks United. This was the brainchild of Michael Gaze, Jeff Anderson, and Sarah Pasquale, the two of which are my mentees. They said, well, we have all these great individual registries. Let's have a network of networks. So they literally built CNU. CNOC was one of the first 5 in there, and now, as you can see, there's more being added, and then more will be added moving forward. But we'll talk about in lessons learned in 1 second. You have to create a database that is flexible, that when you start interacting with other networks, you have a means to talk to them and identify individual patients and link patients. So 2 more slides. So from my perspective, over the last decade, helping to form CNOC, we were the first co-chair, building this database. What did our team learn? Well, first, and Tara talked about this the other day, registries versus research databases. Registries have lots and lots and lots of patients with very little data. Research databases have lots and lots and lots of data with a very few patients. So when we created our database, it wasn't going to be just a registry, but it couldn't be a research database. You have to be very judicious in terms of how many variables you get so that there's not a significant burden on the sites gathering the data. You have to look specifically at what are the goals that you're trying to achieve. And I showed you the mission and vision statements because that was our North Star of what data we were collecting and why we collected it. Create the modules or components required today, but plan for tomorrow. And again, create this flexibility in how the database is constructed and think about expansion when you build your first iteration. Don't build it so it's so narrow and inflexible that then as the field changes and you have to add to it, you can't do that. Don't recreate the wheel relative to data capture. We just went right to Arbor-Metrics because they already had PC4. Start with a small number of sites and perfect data capture, quality assurance, quality control, data extraction prior to large expansion. We started with 5 centers, rolling this out. We found a lot of issues that we had to correct. And then we went from 5 to 15. Then we went 15 to 30, and now we're at 35, soon to go to 45. QA/QC process with robust error reporting and data monitoring ensures you won't have garbage in, garbage out. Jeff and what he showed you with STS is a perfect example of that. You have to monitor the data. You have to know it's accurate. Otherwise, what you're putting out there is not legitimate data. Finances is everything. You have to invest significant resources in the data infrastructure. If you don't, you will have basically data that will be useless to you. And you have to have hard money, revenue source that can grow over time. We did this through dues and with expansion of sites. If it's on soft money from a philanthropist or from a grant, it goes away and then it just crumbles. Your annual meetings have to break even or make money. When we have our CNOC meeting every year, we run it to basically run even or make a few dollars. You can't siphon off the money that goes to your database to the annual meeting. Have nationally recognized dedicated DCCs, DACs, and core labs to create credibility and ensure success. And then from your mission and vision, have some early high-impact projects that will show ROI, significance, and impact. Thank you for your time.
Brad, thanks for a fantastic talk and congratulations for all your tremendous work with CNOC. I can assure you, in my role as editor-in-chief of Cardiology in the Young, our journal placed massively high value on our collaboration with CNOC. We're happy to publish all of this academic content And even the abstracts from the meetings of CNOC are going to soon be published in Cardiology and the Young in an upcoming issue. That's because of your leadership, and congratulations, good work. Our next speaker, Misa Salim Hamoud, is a rising superstar at the Cleveland Clinic. I've had the pleasure over the last year during my visits to Cleveland to watch Misa present a large number of different research projects that she's been involved in, and the work she does is impressive. Her presentations are great. I've seen her give great talks at CHSS, and we're very happy to have Misa on the podium today.
Thank you. Thank you for the privilege of the podium. My name is Misa. I'm a research fellow at Dr. Tara Karam's congenital lab at the Heart and Vascular Institute at the clinic, and the first-year student in Masters of Science for Clinical Research at Case Western Reserve University. So today we will dive deep. Okay. Thank you. Today we will dive deep into the lessons we learned from the CCTGA database at the clinic by going over some of our published data, followed by the ongoing new data. I have no disclosures. Dr. Tara Karam discloses a relationship with Edwards Lifesciences. First, I present to you a 4-year-old boy with CCTGA and a moderate tricuspid valve dysfunction and a normal ventricular function. What would you do for this patient? Anatomic repair, physiologic repair, or PA banding? This dilemma of choosing the optimal therapeutic pathway for CCTGA patients prompted our first study done by our group at the clinic on 240 patients, in which we aimed to describe the characteristics and long-term outcomes in terms of survival and systemic ventricular and valvular function across the therapeutic spectrum. This flowchart demonstrates the cohort and their treatment pathways. 46 underwent definitive repair before presentation at CCF and are not included in further analysis. Among the remaining patients, 40 patients were treated expectantly and thus referred to as non-surgical, and 154 underwent a surgical procedure, which were 79 anatomic, 45 physiologic, 24 Fontan, and 6 underwent a primary heart transplant. Our Kaplan-Meier plot for the cohort stratified by the repair pathway shows that survival for anatomic repair in green showed excellent durability over time. The overall survival was 81% at 15 years. As for the physiologic repair patients, as shown in blue, sorry, I'm going to repeat it. Our Kaplan-Meier plot for the cohort stratified by the repair pathway shows that the survival for the anatomic repair shown in green showed excellent durability over time. The overall survival was 81% at 15 years. As for the physiologic repair patients shown in blue, they performed equivalently initially, but then there was a late attrition at around 13 years. The overall survival at this group was 69% at 15 years. As for the systemic atrioventricular valve and ventricular function, in the patients who underwent anatomic repair, the graph on your left shows mitral valve regurgitation, which increased over time. At 1 month, 11% had moderate regurgitations, which increased to 15% at 10 years. The graph on your right shows the trend of the left ventricle dysfunction over time, which was 15%, but then gradually increased to 28% at 10 years. On the other hand, in the physiologic repair group, the graph on the left demonstrates the grade of the tricuspid valve regurgitation over time, and on the right, the degree of the systemic right ventricle dysfunction over a 10-year period. There was an initial rise of the percent of patients that had a moderate regurgitation in the first 5 years, then declined because of the tricuspid valve interventions, which occurred in this cohort, and that were a total of 10 tricuspid valve repair or replacements. However, despite interventions to improve the tricuspid valve function, right ventricle dysfunction persisted gradually, increasing from 65% at 1 month to nearly 84% at 10 years. So what would we do for our patient? Many would advocate for anatomic repair. According to this study, patients seem to have a better survival on the long term and anatomic repair. Mitral valve and left ventricle dysfunction can occur over time, but seem to stabilize later on. Moreover, tricuspid valve intervention after physiologic repair does not rescue the failing right ventricle. And long-term survival and physiologic repair may be impacted by worsening right ventricle function. But we are missing a big part of this equation here. What is the patient's perspective in all of this? i.e., the health-related quality of life outcomes. The Congenital Heart Surgeon Society has shown a great interest in assessing health-related quality of life outcomes in DTGA patients. The authors assessed health-related quality of life outcomes in arterial and atrial switch groups utilizing the Pediatric Quality of Life Inventory Instruments, i.e. the PIDS QLL questionnaire. The number of responders was 95, 71 of which had an arterial switch repair and 24 had an atrial switch. The core scales of the PIDS QOL questionnaire included domains for the physical health, psychosocial, emotional, social functioning, and work functioning. And it also included a total summary score. The arterial switch repair patients reported scores similar to the healthy reference group population in all domains as shown in the red box, whereas the atrial switch patients reported significantly lower physical scores compared to the healthy reference populations as highlighted in green. When comparing the arterial switch patients with the atrial switch patients, although not statistically significant, the authors found that the arterial switch patients reported higher scores compared to the atrial switch patients. In summary, one of the major take-home messages of this CHSS study was that the arterial switch operation overweighs the atrial switch in terms of health-related quality of life outcomes. Now, the exciting part. What about the CCTGA patients, which is a more rare entity? We aim to assess and compare patient-perceived health-related quality of life outcomes in adult CCTGA patients across the 3 treatment pathways, the non-surgical, anatomic repair, and physiologic repair patients. We utilized a novel instrument derived from 2 validated questionnaires for measuring health-related quality of life outcomes, the PROMIS-10 mental and physical domains, and the McNew social domain. This instrument was validated at our institution on multiple and different adult cardiac populations as patients who underwent the Osaki procedure, the Rose procedure, and the mechanical AVR. Therefore, we elected to use it in an adult congenital cardiac patients. We chose to use this hybrid questionnaire due to the significant overlap between the 2 instruments, significantly reducing the number of questions patients had to answer, thus increasing the number of willing responders, bearing in mind that the social domain is the unique aspect of the McNew instrument. Looking at those who responded, so far, we were able to reach 45 patients, 17 in the non-surgical group, 12 in the anatomic, and 16 in the physiologic, with follow-up still ongoing. Let's take a look at these scores. For the total 45 responders, the PROMIS-10 mental score seen by the pink box plot was equivalent to the normal reference population values represented by the red horizontal line. However, the PROMIS-10 physical score was lower than the normal reference population. As for the McNew social score, it was significantly higher than the population norms, again represented by the horizontal red line. As for what about the health-related quality of life outcomes among the treatment groups? Physical scores tended to be higher among the anatomic repair patients, represented by the green box plot, compared to the non-surgical and the physiologic repair patients. The Mantle score was equivalent between all treatment groups, same color codes. Again, we see a higher McNew score in the anatomic repair patients, but there are no statistical significance in these scores, bearing in mind the small sample size of these groups. When we compare the anatomic repair versus the physiologic repair, we saw that the scores were higher in all of the domains in the anatomic repair patients, giving a signal that these patients are doing well on the long term in terms of health-related quality of life outcomes. In conclusion, long-term health-related quality of life data may inform CCTGA patient selection and triage. Health-related quality of life gains among adult survivors with anatomical repair of CCTGA may encourage enthusiasm for proactive management of balanced CCTGA towards anatomic repair. Our future directions. The statistical team at HVTI is currently working on time-varying covariant analysis in which we will incorporate longitudinal clinical data as echo-variables, cardiac operations, and crossover from one group to another with survival and health-related quality of life outcomes. So stay tuned for our paper. Thank you.
Well, I'm going to introduce our next speaker, who probably doesn't need an introduction. It's Dr. Jean Blackstone at Cleveland Clinic. Jean, are you on?
Yes, I am. Can you hear me?
We can hear you. We don't see you, though. I see your slides. Good morning to you.
That's fine.
Oh, you don't. Are you in your pajamas? Oh, no, you're in your suit and tie. It's so good to see you. I have not seen Jean Blackstone in a long time. So, Jean, welcome. I can't wait to hear your talk here.
Okay. Thank you very much. I have no disclosures. In this talk related to information management and data science in medicine, I will highlight 10 lessons from the past that I think are valuable for today and into the future. From the first series of 8 patients who underwent cardiac surgery at Mayo Clinic supported by a mechanical pump oxygenator, cardiac surgery has been driven by data. This was unlike most medical disciplines in the 1950s. However, John Kirkland, who led that first series, warned, quote, enthusiasm, an important ingredient of success, can lead subtly and easily to loss of self-criticism and incomplete reporting of unfavorable aspects of a new field, end quote. His lesson, our true progress must continue to be based on research done painstakingly and accurately and on experience, honestly and wisely interpreted. Technology. In 1959, my introduction to databases was a stack of notched cards and a mechanical sorter. I used plugboard programming to analyze cardiopulmonary bypass data and was happy when we got our first paper tape reader. When I moved from the University of Chicago to Birmingham, Alabama, I encountered this IBM 1800 data acquisition and control system in a 2-story room next to the cardiac intensive care unit. The project started with IBM at Mayo Clinic, envisioned that care and treatment of post-cardiac surgery patients could be done best using numerical data and an orderly set of rules. Load cells and pressure gauges were inputs, and control of infusion pumps for blood, fluids, and drugs were outputs. At the top, blood pressure was controlled within narrow limits by drug infusion recorded at the bottom. That 2-story room full of technology had less computing power than your iPhone. Lesson 2. All technology and analytic methods become obsolete. Use them courageously to their full capacity, understand their limitations, and work to develop new technology and methods to better answer questions and care for patients. Documentation. Information is prelude to data. 1970, code at IBM described a database structure for sorting and retrieving data. Relational databases were comprised of tables representing relations, and each table represented an entity type. Columns were attributes of those entities. Rows were instances of the entity types. Importantly, columns could stretch widely to contain many attributes, but adding new columns required reconstituting the data model. 1993 with IBM, we challenged the relational model because we believed that medicine would continue to evolve and a data model was needed that could be easily extended to embrace new knowledge. What if we turn the relational model on its head and develop content from decouple content from the database structure, get rid of multiple tables, make columns generic attributes that could apply to any type of data today or tomorrow? We joke that it should be able to contain the most complex medical information and your grocery list. Then other rows describe the entity, the attributes, and the data. This meant that the database would be narrow and long with thousands of simple rows. This would be the way for a database to have unlimited extensibility as new knowledge developed. This model was implemented by IBM with us, and the response times in the 1990s was less than 300 milliseconds. The last years of Dr. Kirkland's life were spent developing what he termed the language of medicine, useful for a computerized patient record system, what today we would call an ontology of clinical medicine. In 2000, now at the Cleveland Clinic, we attempted to simplify further this database model, transforming it into a graphical structure consisting of nodes with edges pointing to other nodes. This was an n-dimensional directed acyclic graph database that by definition was simple, infinitely extensible, and self-documenting. At a microscopic level, data elements looked like this. Still in 2023, complex data models are ubiquitous, they are unnecessary, they encourage proliferation of uncontrolled special purpose databases or spreadsheets, poorly documented and hard to federate with other data. This impedes analytic work. Collaboration. Look again at the first page of this report of the Mail series. Note that the authors plus IBM engineers represented at least 5 distinct disciplines. Here's a list of non-medical disciplines of informatics collaborators with whom I have worked over the past 60 plus years. Again, from Dr. Kirkland, quote, excitement is at the interface of disciplines. Analytics. Perhaps I am best known to you for either inventing, developing, or introducing novel analytic methods. These were born of necessity when we posed research questions for which there were no or suboptimal analytic methods. These included a 10-year quest to develop a method to analyze long-term cardiac surgery data that had an early high post-operative risk. This multi-phase model incorporated separate streams of risk factors that modulated the area under the early hazard phase, raised or lowered the constant hazard phase, or tilted the late hazard phase, and you've seen lots of these in CHSS publications. Poppet escape from Brownwell-Cutter aortic valve prostheses introduced us to Wayne Nelson, a statistician with General Electric who introduced us to repeated and weighted events. Many visits from Brad Efron from Stanford introduced us to machine learning in the mid-1980s. My first Cleveland Clinic hire was Hemant Ishwan, who led our NIH-funded developments in machine learning in all areas shown here. The lesson, as analytic barriers are encountered, develop or embrace new, more appropriate methods rather than settling on less appropriate ones. Individuals. Although we continue to develop and participate in clinical trials and use propensity score methods to obtain average treatment effects, in recent years we have focused more on individual treatment effects, the basis for precision medicine. Why? Well, in another field of rare diseases, esophageal cancer, these are data about esophagectomy alone on the left and neoadjuvant therapy on the right. Red lines are the average treatment effects, closely mirroring findings of clinical trials. Gray lines are predicted survival, though, for individual patients. Notice their huge variation above and below the average. This allowed us to predict in bars going upwards how many patients actually received the best treatment and how many in bars pointing downward would have had longer survival with an alternative treatment. Tonelli and Short claim that, quote, as long as evidence-based medicine insists on a hierarchy of evidence, emphasizing population-based knowledge, it and precision medicine are not reconcilable, end quote. Stars. Coronary bypass grafting transformed cardiac surgery from operations for congenital heart disease and valvular heart disease to a cottage industry of gigantic lucrative proportions. It was studied academically in trials such as the much debated NHLBI-sponsored coronary artery surgery study beginning in 1973, comparing CABG with medical therapy. Everything changed again when the Healthcare Financing Administration publicly disclosed raw CABG mortality data by institution. In response, the Society of Thoracic Surgeons Standards and Ethics Committee proposed that the STS develop a national database with risk adjustment one of its major goals. It primed the pump with legacy data from the 1980s, accepted new data in 1989, and targeted mostly community hospitals. I don't have to remind you that dozens of rating and ranking initiatives sprang up, largely focused on CABG mortality. Risk adjustment was based often on administrative data, but also on clinical data, as with the STS National Database. This initiative, introduced with the intention of reducing mortality variability and improving patient outcomes, had many unforeseen consequences. Institutional reputations were on the line. The information was used for advertising in an increasingly competitive environment. Surgeons found ways to game the system or avoid operating on high-risk patients. At the same time, reports were issued at such wide intervals that they were not very useful for quality improvement. To paraphrase Dr. Kirkman again, outcomes metrics, an important ingredient of quality improvement, can lead subtly and easily to loss of self-criticism and incomplete reporting of unfavorable aspects of a mature field. Goodhart demonstrated that any observed statistical regularity will tend to collapse once a pressure is placed on it for control purposes. And Dr. Strathern stated that when a measure becomes a target, it ceases to be a good measure. Time horizon. We focused on short-term outcomes, but patients consent to complex heart surgery expecting long-term benefit. However, most long-term studies of treatments are not that long-term. Consider coarctation. Fixed in the 1960s with patch graft that developed a pseudoaneurysm. In the 1970s, coarctation with calcification led to a third operation. More problems developed in the 1980s, and now at age 50, this patient had no pulse in her left arm and faces a fifth operation. Findings include a big heart with a stenotic disrupted conduit, subaortic stenosis, a regurgitant bicuspid aortic valve, and an ascending aortic aneurysm. In the past, we have had a short horizon, good surgical metrics our institutions are proud of, a myopic view. If we put patients first, the horizon must be long-term, as was emphasized yesterday in the talks. Regulations. The 2001 vision of the Institute of Medicine for a Learning Health System was at its core an informatics vision. Its goal was that by 2020, 90% of clinical decisions would be supported by accurate, timely clinical information reflecting best available evidence. It is 2023. The technologic state of informatics is not the barrier. Rather, medical record systems are not aligned with the Institute of Medicine's 2020 vision, and regulatory hurdles prevent its being accomplished. On that distressing note, dissatisfaction with the current state may be the key to progress. Dissatisfaction with the current state of data, technology, analytic methodology, incomplete knowledge, and regulations presents opportunities to develop better data models, faster and more capable technology, and new analytic methods for generating new knowledge for better care of our patients. Thank you.
Thank you, Dr. Blackstone. That was an excellent talk. Next, we have Dr. David Chen, who leads the AI and Informatics and Health Lab at Cleveland Clinic, and Ishan Sharma, who's a data analyst in that team.
Thank you very much. It's going to be a challenge and honor to follow Dr. Blackstone. I greatly recognize that we stand on the shoulder of giants. Ishan also helped me with this presentation. He's a very active member of our collaboration and of our the data infrastructure. So in the past couple talks, you've heard a lot about like how data is being used to create all these new knowledge. And I hope in the next 10, 20, 30 years, we'll be using even more data and even more technologies to create new knowledge. I do have a research agreement with the CASA. So here's a vision of tomorrow's doctors, right? And this is a vision where tomorrow's doctors have every piece of data ever available to mankind at their fingertips, and they can create the best piece of intervention for a patient as possible. They can really personalize that care. 5 years ago, I would have said this is way out in the future, but I think we're getting closer and closer to that goal. For one, we have tools that allow for enterprise scale, highly scalable extraction of data from free text. So one of the things that Dr. Blackstone talked about was, and others have talked about, is how time consuming and how expensive it is to get good quality data, to extract it from text. It's a very manual process. However, with tools such as MedTagger, CTAGs, and CLAMPS, we actually, what these tools do is they formalize dictionaries, they formalize syntax using programming, and they can take out that data. So instead of a simple text search that you've used in Word or Google, this one, what it actually allows you to do is understand that, hey, there's context around that entity. So for example, if we're looking at syncope, my patient has talked about they have a family history of syncope. You can still extract the fact that there's syncope, but you also extract the fact that there's knowledge that this is not specifically related to the patient, but rather their family. So that's very powerful. So how do we apply that to a clinic? Well, you can create these dictionaries, and also you can actually program the specific context that you expect these terms to come out to, and you can apply them. you can actually apply them directly within the clinical infrastructure, enterprise data infrastructure. And this allows you to create real-time, or at the very least near real-time data and clinical decision support with very, very high accuracy. Now, the limitation of this is it's still fairly intensive. It's still fairly manual, right? You need a lot of expertise to use these tools, and also you kind of build them one by one. Of course, there's also, I guess, large dictionaries such as UMLS or SNOMED CT, but they aren't necessarily tuned to your data. So these tools do need some tuning. Another aspect is how we treat our data. So classically, the way we treat our data is like, hey, there's an event and there's all these variables related to event. However, that's not always the case, or actually that's never the case. What really happens is like there's this asynchronous nature of data where, hey, your patient gets a lab on time A, and then your patient gets another lab at time B. What that does is that introduces levels of uncertainty within the data. Now, what we know is that uncertainty can actually be informative. For example, you don't order a troponin unless you think someone is getting a heart attack, right? So the fact that there is no troponin ordered is actually very important, or the time from the last troponin order is very important towards a potential decision support or potential knowledge. And now we actually have models that can incorporate that time, learn a little bit of that uncertainty. I showed the very simple unrolled recurrent neural network. The idea is that at each time point, the network ingests your data from each time point, and then it can also pass on the data ingested from a prior time point to the current one. And at each time point also provide a prediction or provide some sort of synthesis or analysis of the data. So now we actually do have the computational power and the computational models to use this data. Another aspect of this is we can reduce your clerical burden. So going beyond kind of very structured data, we can also look at unstructured text. So I'm sure a lot of you have heard about ChatGPT. It's a revolutionary AI program that really tries to replicate human speech patterns. Now, it is very powerful, and there is a world where you may be using that to synthesize your patient's clinical history. You may be using that to synthesize all the possible knowledge out there in PubMed. However, I just want to, that is at the cusp of, that is a tool that's at the cusp of implementation. But I also want you to understand that these tools do not actually have intelligence. There's no context to these tools. So like you may be able to identify the proper suture or the proper approach for your patient, but this tool does not understand the fact that what if it gets it wrong? There's no loss function that tells you, okay, if I get this wrong, then my patient will die. So that's something that you have to be very careful of. I'll skip this just for the sake of time. Another aspect of data that we haven't really gone into is the vast amount of unstructured data or complex data, such as imaging. Imaging is obviously a really important part of your daily operations, and it's an important part of your function. And that is also a piece of data that is very complex to analyze and integrate. But it is getting to the point where a lot of these models are able to leverage the huge amounts of retrospective data to get close to human performance in terms of diagnostics, in terms of segmentation, the tasks that you work on. Now, typically, this is done for adult cardiac surgery, as seen here. Now, you can also, because the awesome nature of data science these days, which makes it very open source, you can also take the very same model that someone has create it and apply it to and transfer it to your pediatric cases, and with some fine tuning, actually achieve very, very good results. So in this case, they were able to identify tetralogy of Fallot with very high performance. Also, within the use of imaging is surgical planning, right? Right now, you can use imaging for surgical planning, but like there's this natural kind of difficulty of getting what's on the screen to what's on your hand or the planning. But today we can also do 3D printing. Now, 3D printing is something that's been around for a while, but new innovations within the 3D printing space and the imaging space together is coming to the forefront, where it allows the 3D printed object to actually mimic the real tissue. So it can the imaging identifies it reflects the tissue characteristics much better. And then the actual printed object reflects that tissue characteristic. So you can imagine you can identify if a piece of tissue is extra friable, or there's a lot of fibrosis in a certain area that you may want to avoid or resect or whatnot. Sorry, I'm not a surgeon. So yeah, that's another use of retrospective data. Analogous to that very physical 3D printed object is the digital object, the digital twin. So one of the things that Dr. Blackstone was saying is like, hey, we're looking at the next day, or outcomes happening the next day or the next month. But with digital twins, there's certainly that potential of looking at outcomes that happen in a year or 2 years or 10 years or 50 years even, because we can now, there's the potential to replicate someone and look at your interventions in a biomechanistic way, and also change your interventions to potentially optimize these the models or the output of these models. Finally, I also want to address the idea that we're not only looking at retrospective data, but we're also looking at prospective data. This is the age of wearables. This is the age of new implantable sensors, and this is going to give us a vast new amount of data. So as some of you know, tracking the outcomes of your surgeries, it might be something that happens, yearly. It's something that's expensive, it's time consuming, it's something that can cause a lot of anxiety. But what if you can do it by just putting in a single implant, or having your patient just wear a wearable? That's on the cusp of possibility. Now, the question is, how do we actually use that data? So obviously, you don't want to be checking in on your person's wristwatch on a daily basis, right? Like, or even potentially an hourly basis. But at the same time, like that sort of data, that data analysis, is not so daunting anymore, because we have AI tools that allow us to ingest and potentially put that decision in a very condensed form in front of you. So regardless of the difficulties of working with data, I want to say that the future of data science within this field is very, very bright. We'll be capturing information and creating knowledge like never before. The tools and data we've used in the past 10, 20, 30 years have largely been aimed at administrative uses. But I think in the next 10, 20, 30 years, what we'll do is we'll actually be using that data for your patients and for yourself. So yeah, thank you.
I'm going to introduce our next speaker, which is kind of in some ways going to put this all together. So Dr. Azra Bojoruk is a Senior Associate Dean for Research at University of Florida College of Medicine, who is really, her research is in the AI field. She's funded. She launched a Intelligent Critical Care Center, which is abbreviated ICE-Q, what the fellows tell me. And she's going to show us how the application, particularly in that immediate post-op phase, which we talked a little bit about the long-term survival, but that ICU phase is critical for our patients. And so Azra's going to update us on the use of artificial intelligence in this space.
Thank you, Dr. Cook, and thank you, organizer, for having me. How do you advance the slides? Do you have a
Just click the mouse.
mouse? That's okay. Well, I'm glad to be here. I'm not pediatrician nor a surgeon. I'm adult intensivist, nephrologist, and neurointensivist, and all clinical informatics.
Michael Dieter has been awaiting a lung transplant at the University of Florida Health Center since December.
I'm what you call high flow air. And because of that, I can't sustain myself.
Sensors and cameras track Dieter's every move in this smart intensive care unit, from vital signs to facial expressions and everything in between.
Every place in this room is sensing something about you. Is this enough light? Is this enough noise? Are you okay? Are you moving enough? Are you in your bed? Are you out of the bed? I think that's the future of how we will design hospital.
More than 350 gigabytes of information per patient goes into a central computer, where artificial intelligence then processes the data.
Well, this is a snapshot of some of the work I will be talking about today. So as Dr. Cook mentioned, I co-lead Intelligent Critical Care Center with Dr. Rashidi, who is my partner, one of my mentees from biomedical engineering. We have about 15 faculty from really different disciplines, from computer science, art, digital art, medicine, statistics, and informatics. And in a truly collaborative manner, what we believe is the transdisciplinarity that this field requires. We really aim to transform how hospital and acute care is delivered using technology in conjunction with clinicians. And working not only on developing research tools, but also implementing this technology and creating the workforce of the future, because I think we are on the cusp of how we will be doing medicine all together. So the pervasive intelligence, or is the concept that Dr. Rashidi and I started almost 10 years ago, and were luckily funded both through NSF and NIH, with the idea that a lot of our work in ICU is sporadic and manual and really depends on human factor that often we don't have enough human or manpower to perform. And whether we can use technology to help us offset that burden on individual human, whether it's a nurse, healthcare provider, or caregiver. So the idea of using pervasive sensing or sensors in environment and coupling them with the AI has evolved over time for us. And we have used it both in ICU for remote monitoring, developing acuity scores, but also for certain syndromes like delirium, where we can actually couple the sensing with autonomous intervention, like changing environmental light or noise. This is the first study that we published several years ago, where we showed our data on using inertia, the sensors that we place on patient wearables, such as shimmer sensors, measuring both vital signs continuously, but also muscle functions with EMG, together with RGB camera and in-depth camera that I use to track facial features, and also posture and movements of the patient in real time. All of that comes on this little IoT sensor, get integrated, and eventually we validate that through our human annotation. And not only use that to determine complex movements or emotions or certain statuses of patient, but also to deconstruct visual cues that we often use in clinical medicine. Like how many times you have entered the room and just said, you don't look good today, right? Most of your models do not use that human perception right now. But what we are really trying to do is deconstruct human faces and movements and see whether those small cues can be added to clinical information and see how that change the prediction or tracking of the surgical or any other risk. So as you can see here, the activity recognition we use, this what you see here is really in-depth camera. You map human bodies in this very de-identified way so we can share this data, and we are creating a large data set of these images. And then using transfer learning, meaning that you can train your data on images of normal human subjects and then use your specific data set to tune the model. We are developing this end-to-end pipeline. So all of these transformers are what actually ChatGPT is. That's a specific architecture of the model where you input a very large data set and then use these attention on a certain features to slowly narrow down representation of the data set in a way that human really don't do. And we, at this point, we're actually able to, from the single shot of human, completely decompose your pose. Similarly, the facial action units use facial muscle responsible for facial expression. You can see you have a lot of these little units, and you define emotions by combining, right? Like happiness is 7 facial action units together, right? Your sadness and so on. It's very interesting. So, but rather than necessarily looking at you happy, sad, or no, we were also trying to decode how combining these features with other physiological factors, actually you can, as example, autonomous pain monitoring or agitation, or for that matter, look how that correlates with your acuity. So here is the end-to-end AU detection with vision transformer. Also, the most recent work, we actually use our annotation toolbox. One of the most difficult part is this is a gold standard validation, the features on the video. You can imagine how many video sequences you have in one video of the patient. It's millions and millions. And we have a human annotators that are now working on self-learning models that once you have a certain amount of data, you can actually not require human adjudication anymore. And here's an interesting one. If you look at this facial action units, and what we look at a very simple correlation between SOFA score. I don't know how many of you, probably many of you are familiar. SOFA is a sequential organ dysfunction score. We use it to define to diagnose sepsis. It's a really 13 physiological signals that are used to adjudicate or quantify your organ dysfunction. And if you look and higher your SOFA score, more acutely ill you are, more likely to die in ICU. So if you look at correlation, you will be very surprised that some of these facial action units highly correlate with SOFA scores. So, but in isolation, none of us would ever think about that. As example, blink or jaw drop, cheek raiser might be actually a feature that inputs in your acuity or prediction of how bad or good you will be doing clinically. So moving forward from Pervasive Intelligence Project, now, can we also, I understand, it is absolutely next frontier combining these new data inputs, type of data. But what can we do with existing data and how we can use them in real time? That was another, this is my first R01 almost 10 years ago, where idea was whether we can use clinically acquired data without any human input and use it in real time for risk surveillance after surgery. I'm adult intensive in surgical ICU. I care about real complications like acute kidney injury, mechanical ventilation, being in prolonged ICU, sepsis or delirium. And over time, we have developed what we call my surgery risk model that track complications after adult surgery for all type of surgery and predicts them both preoperatively, but then also use intraoperative data to dynamically adjust risk based on events in surgery. And you can see here, we published quite a lot and just developed prospective validation of this model. This runs in real time. We have built a real-time analytic engine in parallel to Epic. So everything comes out of the Epic, goes in our platform and provide risk scores that now come to surgeons on a mobile platform. And we are also importing them in Epic. I want to show you a couple interesting things here. The next frontier for us, taking this intraoperative data from physiologic monitors and waveform data, and then incorporating them again in a transformer architecture where we can develop explainable, uncertainty-aware, and multitask deep neural networks. So what does it mean is that you can see here all physiologic time series that are collected during surgery, and we can actually go back, identify in time in which part of this physiological time series actually contributed to a certain event that we are looking at. So you can see here it's different for single patient, different times. It's also interesting that we are now not only providing your risk surveillance, but also uncertainty of the model around the prediction, because there are certain thresholds at which models should not be casting prediction, right? And here you can see that the human context and human domain expertise is absolutely critical for these models. Another really exciting work is by mentees, Dr. Tyler Loftus. He's surgical attending in acute care surgery. He started as my fellow and got his K award on day one of his job as an attending. He now has his first R01. He took our My Surgery Risk model and then started working on how you can match intensity of care with the severity of illness of the patients, and demonstrated that both over or under triage to ICU based on what our model predict as opposed to what's happening can lead either to missing certain events or delivering low value of the care. And I think that is the next frontier for us, how to actually use these tools in real clinical workflow and start with something as simple as triage, because I think as we move more on a more complex decision, it will require much biggest investment of all of us as a stakeholders. And here's a very simple example, because I'm a nephrologist. Acute kidney injury is really my expertise. I've done a lot of work in perioperative and postoperative AKI, both short and long-term outcomes. I'm going to show you a little bit about how this SIM model can help you streamline some of your decisions. And here you can see the patients who in My Surgery Risk, preoperative risk assessment, had low risk for AKI. And then what we did, we added the intraoperative data on the top of that. And based on intraoperative data, you can see here, we identify among those patients who had no risk for AKI before surgery based on their previous medical illness, planned surgery, a lot of other factors that contribute to our risk. You can see that based on what happened to them, the risk has changed. Now, each one of us, that is absolutely expectable, right? The risk is not a static. I can have a healthy person who goes in the OR, bleed, develop hypotension, get a lot of nephrotoxic drug. That person is not the same person who entered that surgery. So similarly, so that's the new net patients at risk identified. Similarly, these are the patients with high preoperative risk scores. What's interesting here, you can see that intraoperative events care very little to ameliorate the risk. So a lot of the preoperative risk in high-risk group was fixed. However, still you can see that we have identified some patients who actually moved to low-risk group based on this. So that net reclassification improvement was about 14% based on our ability to dynamically adjust the risk over time. And we are moving that now to the daily. And if you look at the things that really differentiate between these two are very little, those things that we do know, and that is the blood pressure and blood transfusion. So there are a lot of things we can do. I get that question often. So what can you do about this? We summarize that in one of our guidelines. There are a lot of things we can do. If we know how to enrich our population in terms of risk, we can really enrich our interventional strategies, but especially intraoperatively and postoperatively. We have a lot of newly recognized tools, at least in adult medicine, such as individualizing your pressure control both intraoperatively and postoperatively, not only your volume. And it is an example that really matters for acute kidney injury. The future in terms of sensing, you can see here previous speakers identified, and there is a proliferation of new sensors, both focused on identifying metabolites and chemical analytics in our labs that we use. So we can expect continuous input of laboratory values, but also in imaging. This is a fascinating paper of the bioadhesive ultrasound that actually images diverse intra-abdominal organs. So those type of data is coming. We have algorithms. What I think we critically need is a new generation of physicians. The workforce will not look like today. So what we are doing at the University of Florida is really developing AI passport program for healthcare workers, because we need to move from not knowing much to being not only literate, but even masters in this field. So with that, I will finish that. We have upcoming AI for Health, first CME conference, really focused towards physician and healthcare providers with a 2 days, 1 day pre-conference workshop with AI bootcamp that we deliver to our own trainees, but we will be now opening it for all participants. It has both early stage AI bootcamp for novices. We also have advanced track with NVIDIA that will provide hands-on teaching for their platform Monai for imaging. That is absolutely fantastic. With that in mind, thank you very much, and I'll take questions.
Thank you very much. Before we move into our discussion section, I know some folks are going to have to leave for the airport soon, so just a couple of notes. One, we've got bag lunches for everyone after our last session for you to take with you, so you're fed before you go to the airport. And then most importantly for your CME, you can claim that at the registration desk if you need any information. There'll be an email sent to you about the course, complete that, and then you'll be able to get your CME. For those of you that are leaving soon, on behalf of Dr. Bleiweiss, Dr. Jacobs, myself, Dr. Naj, I want to thank all of you for coming. It was an amazing 3 days, and this session was just spectacular. I'm going to hand it over to Dean Cook. I know she's got a lead-off question for us.
Well, we've got people in the aisle. I'll just ask 2 quick questions. I've got like 100, and I have some written down. So first to Dr. Bohorak, since you're still up here. You talked about workforce development. So you think of all these sensors and the types of data coming in. We looked at some of the discrete fields for our STS database and things like that. How, one, how do we train a workforce, and what computational infrastructure do you need to be able to do the work that you're doing in the IceCube?
Yeah, thank you for the question, Dr. I think it's critical that we start developing training resources from the medical school. One of the things that the University of Florida we have is now a curriculum, AI curriculum for our students. We open it up as open source eventually to everyone. And then based on that, start more towards hands-on experiential learning for both physicians and engineers who need to be trained actually in medicine. That transdisciplinarity is the key. In terms of infrastructure, we do need open source data. That is the future that we cannot escape. Everything will be open source, but we also need open source tools and standards. And a lot of that work is now being done and really supported by NIH and NSF.
Mm-hmm. And then just a second question, and then we'll get to the aisle. This is for Jean Blackstone. So Jean, if you think back in the Kirkland days, we had descriptive analytics from these big data sets, and then we have predictive analytics, and we want to move toward prescriptive. You taught really the cardiac surgical community and many of us who do research in this space all about the proportional hazards modeling and propensity methodology and things like that. There's many different models now that require data scientists or at least knowledge of what the data scientists do to guide them. Can you talk a little bit about, you'd heard a little bit about recurrent neural networks. How would you educate the cardiac surgical, cardiac anesthesia, our advanced practice providers in this new methodology that's going to be used to analyze this big data? What do you think?
Okay, number one is that I don't think that you need as a medical person to know all the intricate details of things. At the time that I got started on things, I had to be educated in statistics, mathematics, and computer sciences. I think that the introduction to the general concepts is very important and the use, but you don't need to put together the transistors. And so I think more and more in the future, we're going to have to rely on people like, say, Dr. Chen and others such as he, who actually be at the forefront of the methodology. But at the same time, those individuals then will need to be able to put, the basic concepts into a language that we can understand, and we should be prepared to understand what they are saying and what they are doing, so they're not pulling the wool over our eyes. But I think in the future, it's complicated enough that I don't believe that a surgeon needs to go from operating on a small kid to running a quantum computer.
Thank you.
But really quick before we get to the panel, Tara is going to leave in 4 minutes because she has a conflicting meeting she has to also speak at. I wanted to ask her one question before she left. I really enjoyed your talk about the Congenital Heart Surgeon Society database, Tara. I know you've got to go quickly. Your question is, you're now all powerful and with unlimited funds, and you can change one thing about the CHSS data center to improve it. What's the one thing you would do?
I think that's already happened. I think the collaboration between SickKids and the Cleveland Clinic is really going to be a prescient way to move forward and do all of the things that we've talked about. Increased virtual faculty, 2 Kirkland Ashburn fellows, really the data science capacities leveraged on both campuses, and the legacy knowledge of what we've done right in so many ways, and what we can do better in the future. So really appreciate everybody. I've got to go, but it's a great session and a terrific meeting, and congratulations to the organizers for organizing such a tremendous event. Thank you all. Bye.
Thank you, Tara.
Thanks, Tara.
Hani.
Great, thank you so much. I was just actually, I'm going to ask Tara, spectacular session. She actually puts in a clear evidence of the publication bias that we have. So, Center 18 does so well in one, but not on the other lesion. And Center 18 ends up publishing their data on type A surgery, but not type B, where they don't do so well. And Center 42, whatever that center, ends up publishing what they are good at, which is the pulmonary artery intact septa, but not the Norwood procedure. And that is really highlighting the true bias in publication. So we really have to understand the registries reflect that a little more, but it's all overall, it's all integrated data. My question is to Dr. Jean Blackstone, and I want to congratulate you for stating, and I'm going to quote you every time now, long-term data is not long enough, because we've talked about this yesterday. It all depends on how long you follow the patients. Is it 30 years? Is that 30 years enough? Is it 40 years? We have seen actually things develop after 40 years with some of the patients operating in their life and earlier in their life. My question to you is, you've worked 60 years of your life trying to bring evidence to cardiac surgical outcome, and you've refined the propensity match as the closest possible thing next to a clinical trial. Having said that, why is it compared to cardiology, cardiac surgeons do not do as many as cardiologists in clinical trials, which is the best evidence that we have? Is it because of the surgeons' personalities that my way is the best way, and that's it, I don't need another opinion? Or is it industry involvement? Or why are we not doing more clinical trials to prove one way or the other?
Well, first of all, barriers. There is an adult not congenital, but cardiac surgery network that is doing trials, but it tells you what the problems are. And that is that it often takes years to develop the data. Generally, one isn't going to study things about which there is some degree of certainty, so that to get equipoise, you're studying things that are likely not to turn out to be, all that spectacular in terms of changing practice and so on. And that's why I think, from my perspective, the idea of being able to look more and more at things like virtual twins and looking way beyond average treatment effects to ferret out how patients are doing with all the variability that individual patients have. I really think that form of precision medicine is probably what will end up ruling the day, rather than the average treatment effects from clinical trials.
Thank you.
Dr. Tretter.
Yes. So my question is to our adult colleagues, and it's generally, what can we learn from the adult world with registries and in our very small heterogeneous patient population? But just to frame it, the TBT registry is one of the greatest success of collaboration between the STS and ACC, some of the larger organizations in our field. And with their TAVR cohort, they only enrolled about 52,000 patients, and they only followed about 50% of them out past a year follow-up. And that's with Medicaid incentives for patients or for providers to be reporting data. So even in this largest registry, the long-term follow-up is pretty poor. If we look at in our field at the Melody Valve trial, we only enrolled a couple hundred people, and it took a subsequent multi-center study where they were able to enroll 2,000 people. We could do some sub-analyses and understand some things, but it's still very limited what we can assess long-term follow-up. So, and then our conference here, we're talking about transposition, congenitally corrected transposition, very rare lesions. So what can we learn from the adult world of trying to improve, like what Brad's talking about, Cardiac United, trying to pool together patients, multi-institutional involvement to improve long-term follow-up for registries.
Yeah, I see you looking at me as an adult, and Jean Blackstone
and
is
Dr.
on as
Blackstone,
well.
Dr.
Yeah,
Blackstone and
well,
yourself.
Dr. Blackstone Cleveland Clinic had the CVIR a long time ago, and Jean, I don't know if the CVIR preceded STS or was developed at the same time, but we'd have a parallel database with the CVIR. In terms of learning, I think, and Jean, you maybe want to comment a little more about federated learning and getting different centers together with aggregated data. And I think Chuck Fraser, someone quoted you about you really can't just look at one center. We've got to aggregate this data. And to speak to Hani, where are you there? You know, your commentary about individual centers having excellent results. I mean, just look in the adult cardiac surgery world when Toby Cosgrove was doing 722, I think was his max, mitral valve repairs. I only say that because it was so painful trying to get 5 cases done for him as an anesthesiologist. His outcomes were absolutely exceptional. Like that would be the place. So if you looked around and someone said, hey, where should I have my mitral valve repair? You'd say Cleveland Clinic. Now, it might be that some other things that they do there aren't as great as maybe Texas Heart, you know, with DeBakey in those days for aortic work. So it's not surprising that certain centers have expertise based on the surgeon and what they do. And Toby's practice toward the end was all mitral valves. Lars Svensson, he's aortic. So I've even had people ask where to send someone. I'm like, go to Lars Svensson. He'll do an ascending aortic. He'll do a composite AVR ascending. He'll get it done, pump time, like 10 minutes. And although he comes off a little cold, but we won't talk about that. But he's fast. So it's not surprising that at certain centers of excellence, there are boutique excellence centers or pods within. Aggregating that data, looking at mitral valve across the spectrum may be really more of where to go, and similarly in the congenital world. Jean, do you have a comment on maybe federated learning or aggregation of these data sets?
Okay, so let me just make 2 comments. One is that congenital heart disease is different from adult anything, in that the models, the thinking around adult cardiac surgery deals with large numbers. We're talking about hundreds, thousands to millions. In congenital heart disease, we're talking about very rare diseases. And so we have to think differently about those. Just think about how many trials there actually have been in congenital heart disease. It's not many, and it's hard to put data together. I showed you a slide about another rare disease, namely esophageal cancer. That data came from all 6 continents in the world. That was a worldwide effort to put together data. NIH funded the actual getting all of the institutions together and getting all the data use agreements and everything around the world. It took 1 year to accomplish that. And that wasn't a randomized trial. It was thousands of patients in the biggest data set in the world, but it's nothing near, say, the TBT data sets and so on. So I think there has to be a differentiation of that. The second thing I would say about your comments, Colleen, is that I think there are new ways of looking at registry data that haven't yet been tapped. I don't think even thought of well yet by the STS and other folks, that we're actually trying to think of in which one can look at variations within institutions to identify within institutions where one can improve what the targets should be for improvement of results. And it comes from your thought that within institutions there are pockets of expertise, and do you think that you can probably identify those in the data sets that we have?
Can I make a comment to this? Just to put this problem in real number context. So Dean Koch, you talked about, Toby Cosgrove doing 700 in a year, right?
Yeah.
So if you look at the top 10 U.S. News congenital cardiac programs in the country, they do between 500 and 1,400 cases a year, the entire centers. And if you add up the top 10 programs, it only adds up to about 25% of all the surgery being done in the country. So even if you just amalgamated, I'm just making this up, the top 10 U.S. News programs and said, we're all going to confederate, all the data is coming to a central place, you're still missing 80% of the data. And that's at the other, 110 programs doing 1 here, 2 there, 3 there. So it's a conundrum. Now, the other thing I'll say is, because it almost sounds like this doom and gloom, when I was training in the 90s, every center, congenital center, and Jeff remembers this, Hani remembers this, completely competing with each other. You would never, ever do a paper together. You would never, ever think about bringing your data together. When you look at what's happened with the CHSS database, the STS database, PC4, CNOC, and I can give you 15, 20 other databases, we're now in an era where everyone is trying to work together. And that's where I think things like Cardiac Networks United are so important, because now we're going to leverage the best pieces of, like, CNOC has the neurodevelopmental data. Okay, well, let's look at the ACTION network, which is all the pediatric VADs. And let's link that with PC4 to do a neurodevelopmental outcome study on the largest population ever done, multi-center, utilizing PC4 data, ACTION network data, and CNOC data. So, Ashi wrote a beautiful set of 8 different barriers here to the question you brought up, Justin. And we could probably spend an hour just talking about that. Unlike the adult population where the numbers are just so great, we've made a lot of progress. Now, are we where we need to be, where we want to be? Absolutely not. But we made a lot of progress in the last 20 years. And I think when we look 20 years from now, when I'm long retired and some of the young folks sitting in the back, I see, our UF students sitting there in the back row watching all this. You'll be the leaders in the field in 25 years. You'll be on the podium here. And where you'll be in 20 years will be completely in a whole other place with all the work that Dr. Chen is doing, all the work that Dr. Porrick's doing to create these connections and the ability to predict individual patients like Gene was talking about. So we're made a lot of progress. We're not where we want to be, but in the congenital space, we have a future.
So I'm going to, but Chuck, before we get to you, I want to say 2 quick things about what was just said here. First of all, Toby Cosgrove would do 700 mitral valves in a year. Or same time, right now in the United States, there's a total of 700 Norwood operations done in the entire country in a year.
That's what I'm saying.
So that shows some of the challenges. The second thing I would say is longitudinal follow-up is hard, and we need to find better ways to do it. And that's whether you're following one surgeon doing 700 cases in a year or one country doing 700 cases in a year. It's still a difficult problem. We can address it by linking disparate sources of data using the Social Security Death Master File, which doesn't really work anymore, or the National Death Index. We could create global unique identifiers like is done in autism. But we really need to come up with new strategies for longitudinal follow-up because it's so important. That was in relation to what Justin just said. Chuck.
Well, I can't miss the opportunity to just explore thoughts from all these smart people. It's the great benefit of this focused conference. I've thoroughly enjoyed this. And so I'd just like you all to help me think about a struggle. I'm entirely capable of speaking out of both sides of my mouth. So I will just tell you that. So I was 37 years old. I'm at the Cleveland Clinic, happily working away. And there was great pressure on me to return to Houston. And that's a complicated topic. But the Texas Medical Center was dominated by 2 very strong people, no question about it. And I have 37 years old. I can't go and run a program. I'm 37 years old. How can I possibly make that work? Until I started asking questions. How are y'all doing? And Dr. Blackstone wasn't even at the Cleveland Clinic then yet. Well, they didn't know how they were doing. So I said, well, I'm not coming until we figure out how you're doing. So we got the Black Book. The Black Book. The Black Book was the death book. 0 survivors for hypoplastic left heart syndrome in 1995. 0. 30% mortality for the arterial switch, 1995. They didn't know it. They didn't know it. And because it was a great Texas Medical Center, we don't need to look at how we're doing. So that was an easy decision. I can do better than a 0. And off we went. And so August of 1995, the first survivor ever of a neuro operation, Texas Children's. And I still see that patient.
Wow.
So I'm a believer in measuring. 100%. I'm a believer in it. But I think Blackstone Rule number 7 alluded to another issue, and which Jeff and I have talked about on the U.S. News and World Report Committee, and we're all struggling with it. And it is a fact, and we can't deny it. Now that we have all these number targets, there is risk aversion in our specialty. And we in Austin have been the beneficiary of that. We got a new program. We're not U.S. News and World Report ranked. Sure, send them to us. We'll take them on. And they come from centers that are top 10 U.S. News and World Report ranked.
Wow.
So our job actually is to help patients with the tools that we have. Our job is not U.S. News and World Report ranking. Our job is, with all due respect, not to feed the dean's budget. Our job is to take care of the patients and their families. And there's no question that the perverse use of registries, et cetera, is negatively impacting patients. There's no question about it. So how are we going to fix this? We have patients in our intensive care unit right now that were told during Feed Alive that there was nothing to offer because of this, because of that, because of this, because of that. And you know what the answer was, Brad. You know why they're there. Because it was going to negatively impact someone's statistics and thereby their U.S. News and World Report ranking and thereby the financial engine. So what are we going to do about that?
Well, I agree with everything you said. And I think you're absolutely right. I think the challenge is, like it or not, those registries are not going to go away. They're going to be there. And just like it or not, U.S. News, unless maybe with some of the current changes, U.S. News is going to do what they're doing, and they're going to be there. So you and I have talked about this, and I think we both agree if the registries are going to be there, U.S. News is going to rank programs. It's better for physician leaders to have a seat at the table and participate in the process. So we've engaged, we try to participate in the process and make it as good as we can. How do we deal with risk aversion? Well, in the absence of eliminating the registries, if they're going to be there, the only way to deal with risk aversion is to make risk adjustment algorithms as good as possible to try to adjust for the risk that these higher risk patients have. And it's hard. And then something that the STS Adult Cardiac Surgery Database is now exploring is for extremely high risk patients to create an exemption process. So
that's what I was hoping you said.
Right. So the
there's
example
got to be an outlier category.
Right. So here's an example. You have a patient that would normally go into the isolated coronary bypass graft model of the STS database, but they're a bilateral amputee with a 30% ejection fraction that weighs 450 pounds and is 72 years old. And without a CABG, they are going to die. And they have an extremely high risk to get a CABG, but maybe they'll live. STS is working on a process to create a committee to adjudicate cases like that the chief of a program can appeal and say this patient should be excluded from our risk model because they're excessive risk. And that might be beyond risk adjustment. That might be a second way to do it and something STS is studying. Hani.
Just in follow-up, I gotta thank you so much for bringing this, Chuck, because this is what happens when you have a surgery that you know that the risk of mortality is over 20% or 30%, and then people would say, programmatically, should we do this patient or not? Programmatically, and this is what the issue comes in. What I would say, these patients will die without this operation. So you do this operation, 20% mortality, but you got 8 survived because you did this operation. Is this the right thing or not for the patients? Of course it is the right thing for the patient. And it's not probably good for the program, but it is actually the right thing to do. And the only solution to this is we do not have in the congenital database the others category. The STS adult program has the CABG, isolated CABG, MVR, AVR, all the 5 or 6 where they evaluate, and then they've got the others. We don't have the others. We have in congenital, every patient we operate on has to fit into the 1 to 5 stat categories. And it doesn't matter how much good risk adjustment you do, you will never match that particular patient that you have to take up. Or you say compassionate therapy. To me, with a 20%, compassionate therapy is not acceptable when you have even a 20% mortality, because then you got 8 survivals. So I'm glad I'm glad this was brought up, and I'm glad there are actually a lot of the Cleveland Clinic staff here, because it is something that we run through every day.
But I'd like to respond to this as well. I think, Chuck, obviously I sit with you, I'm with Jeff on the committee. And, you know, what I love about that committee is that we have many voices that make sure that we're not putting things in US News that, well, at least you can't say never, but that's really hard for people to twist and pervert and game the system. I will tell you personally, I left the program. I specifically left the program, and we were ranked number 2 in the country because we were letting kids die because they were too high risk and it was going to hurt our US News. I literally left the program. I was like, I can't be part of this. I can't work as a cardiac intensivist, have kids that I know that if my surgeon goes in the OR, this child has, look, maybe it's not a 95% chance of survival, but there is a chance here that we get this kid through. Now I come to Cleveland Clinic. We take on everything. We are the last stop. And Hani says this all the time. Now, for us to be the last stop, we have to do all the cases that we're supposed to do well. And we do. And that gives us the luxury of taking on a PIVS baby who's dying, who's not going to get to transplant, and doing for the first time survivor double shunt, BTT shunt, and an aortic tricuspid valve shunt, who's still waiting for transplant but is now 7 months old. Doing a fetal tumor removal in a mother where that baby's literally dying in the next 48 hours. But that takes courage. And I'll tell you that you know, when I look at US News now, I feel like one of our roles as stewards of that process is making sure that we can't have people pervert the system. We can't have people game the system, but at the same time, allow the centers that are brave, that are courageous, your program, right? Our program, Boston, for example, they take on everything. They do it all, right? To have that opportunity to do it and not be negatively impacted by US News. The other thing I'll say is the goal is not to be number 1 in US News. The goal is in a fair process to be evaluated and be somewhere, I think, in the top 10. Because there's no way we can completely risk adjust. There's no way that we can, for every single patient, have some opportunity to make it that in some way, those programs that are courageous aren't going to get dinged in some way. But I think if we all work together as a community to minimize it, you can have a process that's fair, equitable, that's going to allow programs to innovate and still be courageous programs. And look, those programs that want to just, you know, work for the numbers and they want to let kids die, I can't fix those programs, but I won't work there.
Yeah.
Well, our collaboration on the US News, I believe, is important. It's hard work, but I think people often ask, why do we even remain involved? Well, because it's going to happen anyway. And I think if it's going to happen anyway, having leaders like Chuck Fraser and Brad Marino in the room to shape the process is important. And I know when I chair those calls and we have a particularly difficult issue, and I ask Chuck to speak about it, or I ask Brad to speak about it, people listen. And we shape what's on that survey and try to make it, it's not perfect, but I think it's better than it would be if we weren't there.
Yeah, I'd be curious what Dr. Blackstone's thoughts are about that. Yeah,
about US News.
No, about this effect that we're describing.
The highest risk patients getting put in the corner to die. Dr. Blackstone.
So let me actually twist that somewhat and take off from the last sentence that Brad had said, and that is the idea of innovation. In 1985, when CHSS database started, you folks who are alive back then may remember that the arterial switch had a very high mortality and the mustard operation had very low mortality. Talk about courage then to introduce an innovative approach that we thought at the time would have long range benefit for the patients. And I think that has been borne out in time, but not until after like 30 years or so. So what do we do about the introduction of new things? For example, your fetal procedures and this sort of thing that may have very high mortality, even today. How does that enter into all this equation?
That's the challenge.
Hani, do you want to speak to this? Because we have this conversation all the time about innovation, courage, being balanced about it. I think it's, and I know Chuck, you and Carlos talk about this all the time. I think when you're a surgeon, I'll just say this with all due respect, I send you the patients, I receive the patients from you, we work together in the ICU, but it takes a very special individual to be able to walk in a cardiac OR with a baby like you do and do what you do, and often with a huge amount of pressure on you to have a certain result. And I think, to what Gene just brought up in terms of innovation, courage, the chilling effect, and Ashu was just mentioning to me, if you think about, the atrial switch versus the arterial switch, that kind of low early more risk and hazard, and then the great hazard later versus the higher hazard early and the great hazard later. I guarantee you, if US News existed in the mustard arterial switch period, we never would have adopted the arterial switch. Go ahead, Hannah.
That's exactly what it is. I mean, I don't want to prolong, but this is these registries and what's supposed to be transparency, which is good, is actually prohibiting innovation and improvement of what we want to do to our patients. And I think really, if I would want anything done in the STS congenital database, is to create the others. And I'm hoping it wouldn't be used as a gaming system to actually offload some of the mortalities that are done after the fact. It should be labeled before the fact, before the surgery is done, not after the surgery is done. This is how it should be worked, so it doesn't get gamed afterwards. I remember always Bill Williams used to say, my mentor from Sick Kids used to say, every dead mortality is a DOR VPS. It's not a tetralogy, so it moved into the more.
Bill Gaynor would say, how do you define double out the right ventricle? It's a patient with tetralogy that died.
Don't go there.
My question about that is about the uncertainty, right? So we've talked a lot today and throughout the conference about long-term follow-up, right? Long-term being 20, 30, 40, 50 years for these patients. And I'm not saying that we know that you invent a new technique. You're great at that. And we shouldn't be penalized for patients that for doing new things to patients when we think that's the right thing. But if the time it takes for us to figure out whether that's the right thing is 50 years, we're not going to know, right? So there cannot be, there has to be that risk between short-term risk to the patient, long-term risk to the patient. I'm philosophically, like, I don't have the answer.
I agree with this, but there's a learning curve with everything. And we ourselves have refined what we do even for the ventricular switches. So I know we're over time, so we need to close this.
I would say that this has been a great section. I would like maybe the dean can give a closing comment.
Well, I just want to thank everyone and thank the meeting organizers. This has really been fantastic. And again, I'm coming from a perspective of a cardiothoracic adult anesthesiologist, but a dean on the side too. So it's exciting, and I love the evolution of how this panel was set up with databases and then going to big data and then to an application of big data with what Dr. Bajorek was doing. So this is really exciting and rewarding. So thank you, everybody.
Thank you.
Thank you very much, everybody. We're going to take a 15-minute break. Let's do that front. And then for those that can stick around, I encourage you to stick around for the debates because Chuck Fraser's a very tough debater and there's going to be some bloodshed.
Uh-oh.